Thank you. Thanks for the kind introduction, and I would thank everyone for joining, taking out their precious time because we all know the best thing we can give for anything is time, and time is the most
Yeah.
precious. So, with this in background, I would share my slides right now. So, I think this for the first time I am having a webinar on one single molecule, and this molecule is rare. I think only a handful of people in the country would have used this molecule, Obinutuzumab. So, knowing that it is rare and where to place this molecule in clinical practice, and is it really required in clinical practice? So, with all these in background, so let us understand what is this molecule Obinutuzumab all about. So, we know that the moment you talk of lymphomas, especially B cell lymphomas, CD20 is the marker that is there on the surface of these B lymphocytes. And the most common garden variety of lymphoma is a diffuse large B cell lymphoma. And then when you look into the chronic lymphoproliferative disorders, majority of these CLPDs are have B cell markers. So CD20 is a very effective target. So just hang on a second. So the only chimeric molecule we have is basically is rituximab, which is a chimeric monoclonal antibody. So, but not all patients who have this CD20, whether it is a chronic lymphoproliferative disease or whether it is a diffuse large B cell lymphoma, not all of them are exquisitely sensitive to this chimeric monoclonal antibody that is rituximab. So the moment these patients become rituximab resistant, then targeting CD20 becomes really a challenge. In these situations, we have a glyco-engineered molecule, which is a humanized monoclonal antibody, the IgG2 type, which I'm going to say, is obinutuzumab. So we have heard a lot of obinutuzumab in majority of guidelines, where in CLL obinutuzumab stands first. So the treatment of a chronic lymphocytic leukemia or the chronic lymphoproliferative disorders have changed dramatically in the last couple of years after the BTK inhibitors have come into practice. So, so there was time when we used to treat CLL with only chlorambucil or chemotherapy, and then we had bendamustine rituximab being there, and then we used to use RCVP, RCHOP, and so on. But the treatment landscape for a chronic lymphocytic leukemia has dramatically changed, where we use BTK inhibitors like ibrutinib or acalabrutinib in the frontline setting, and obinutuzumab comes handy when you combine obinutuzumab with these BTK inhibitors. So, in a high risk CLL where we have 53 deletion, obinutuzumab comes handy again, where we can give this patient. So, this is a more potent anti CD20 when compared to rituximab, and this potential anti CD20 humanized monoclonal antibody works on rituximab resistant cells, which is the unique thing about this particular drug. And I will tell you how it is different from rituximab. What is this glyco engineering of the FC fragment, where you remove the glucose moieties? Just by having some glyco engineering, you can have a more potent drug that is active on rituximab resistant clones. So Roche has been very handy in developing these molecules, and we have seen success with Kadcyla, the TDM1, which you see in breast cancer. Again, it's an antibody drug conjugate. So the technology has been mastered by Roche, and this is one of the unique molecules we have, obinutuzumab, which is the to address the unmet need of rituximab resistance in hematological malignancies. So with this in background, let's go ahead and understand what is this obinutuzumab and how different it is from the garden chimeric rituximab, which we have at present in practice. So obinutuzumab basically is a humanized monoclonal antibody which is anti-CD20. We call it as B selective and B effective. So, and the brand name is Gazyva. So it is a specific design that is based on the standard of care anti-CD20 backbone strategy. So CD20 is expressed on diffuse large B-cell lymphomas. It is expressed on chronic lymphoproliferative disorders, including CLL and other CLPDs like follicular lymphoma, and so on. So the anti-CD20 monoclonal antibodies are classified as type 1 or type 2 based on the cell surface binding and functional activity. So this obinutuzumab is basically a type 2 humanized monoclonal antibody, and you can see in the right side the picture how the glycoengineering has been done in the FC portion of the monoclonal antibody. You can see the anti-CD20 monoclonal antibody, the FC portion, and the free chains that are there are. So Gazyva is the first glycoengineered type 2 humanized anti-CD20 monoclonal antibody, and glycoengineering removes sugars from the FC region to increase the binding affinity to and activation of immune effector cells to enhance antibody-dependent cell-mediated cytotoxicity and also antibody-dependent cellular phagocytosis. So, how does these antibodies really kill the target cells? So whether you take rituximab, whether you take obinutuzumab, they target those cells that express CD20. It is a very potential anti-CD20. It affects normal cells which express CD20 too. So the way it's lethal to cancer cells is by ADCC and ADCP. So obinutuzumab is unique, or it is different from rituximab in that it has a better ADCC and a much better ADCP. So in preclinical studies, there has been a comparison of Gazyva and rituximab, and this has shown an increased indirect cell death induction, enhanced ADCC and enhanced ADCP, and there is a reduced complement-dependent cytotoxicity. So these are the unique things that we have of obinutuzumab when compared to rituximab, which is a garden variety of anti-CD20 activity. So what are the indications? So what are the indications of obinutuzumab in clinical practice? So we have approval basically for chronic lymphocytic leukemia, so in combination with chlorambucil. And number two, we have approval in follicular lymphoma in combination with bendamustine, followed by Gazyva maintenance. So as of now, the approval is for this. So it is indicated in adults with these two indications, CLL and follicular lymphoma. In CLL, we have got approval in combination with chronic lymphocytic leukemia. And in follicular lymphoma, we have its approval in combination with bendamustine, followed by obinutuzumab maintenance 2 monthly. So this is the follicular lymphoma indication is mainly for patients who have not responded to or who have progressed on rituximab containing regimen. So the moment this follicular lymphoma becomes resistant to rituximab, it's an unmet need to address this difficult to treat population. And here we have a glyco-engineered anti-CD20, that is obinutuzumab, and the clinical data would be presented in later presentations, but it has these clinical approvals and it has a preclinical better activity than rituximab in terms of ADCC or in terms of antibody-dependent phagocytosis. So we have this unique scheduling as far as obinutuzumab is concerned, and we know how we position rituximab. We position rituximab in a 3-weekly regimen along with R-CHOP, or we keep it B plus R. We give every 28 days, and then in an earlier stage follicular lymphoma, we do give weekly rituximab for 4 weeks, followed by observation or followed by maintenance. So there are different regimens for rituximab: 3 weekly, 4 weekly, or even we also have Uh, yeah. So or even, we also have weekly regimen. So having said that, obinutuzumab has a different schedule when compared to rituximab. So it has a different schedule for CLL and it has a different schedule for follicular lymphoma. So let us understand the schedule for CLL first. So if you look into the schedule on day one, so you must remember the dose of Gazyva is rounded. It is 1000 milligrams per dose. So in CLL, on day one, we administer 100 milligram, whereas on day two, we administer 900 milligram. So it is 100 day one and 900 day two. That's it. This is in the first week of infusion, whereas on the subsequent weeks, day 8 and day 15, it is 1000 milligram flat and 1000 milligram flat. And then from cycle 2 to cycle 6, it is 1000 milligram on day 1 only. So you have an initial intense weekly regimen followed by monthly infusions. So to add more into this, the first day, the first infusion is divided day 1 and day 2. That is 100 and 900. And the rate of infusion is the standard. We all know how we have to infuse rituximab. These are monoclonal antibodies, and infusion related reactions are quite many. So you have to administer on day one 100 milligram. You have to administer over 4 hours at 25 milligrams per hour, and we slowly increase the duration of infusion, and we go up to 50 milligram, and then we go even up to 400 milligrams per hour if they're tolerating well. So we must remember the schedule. There is an initial weekly intense schedule followed by monthly maintenance. So on the first week, we divide obinutuzumab into day 1 and day 2. Day 1 is 100 and day 2 is 900. So whereas if you look into follicular lymphoma, here we don't have this day 1 and day 2 thing. So we give day 1 weekly for 3 successive weeks followed by monthly. And then we give maintenance every 2 monthly until progression. So very clear, in CLL, we break into 100 and 900 on day 1 and day 2 because of higher incidences of adverse immune infusion related reactions, whereas in follicular lymphoma, it is weekly, straight 1000 milligram, day 1, day 8, day 15. And then we have monthly infusions up to 6, followed by every 2 monthly for 2 years. So what is the standard dosage for relapsed refractory follicular lymphoma? So for patients with follicular lymphoma who have relapsed or who are refractory to rituximab or rituximab containing regimen, Gazyva should be administered in 6 28-day cycles in combination with bendamustine. In relapsed refractory patients who achieve complete or partial response or have a stable disease should receive Gazyva every 2 months until disease progression or up to 2 years. So we also have evidence here for Gazyva maintenance post B plus R in these relapsed refractory follicular lymphoma. So if it is follicular lymphoma, it is weekly for 3 consecutive weeks, and then we have monthly for 6 months, followed by once in 2 months for up to 2 years. And we always have the initial infusion at 25 milligrams per hour, and then we slowly increase if there are no reactions up to 400 milligrams per hour. So what if delayed or missed dose? So if a planned dose of obinutuzumab is mixed, it should be administered as soon as possible, and we should not wait until the next planned dose comes. So these are basically these are the most potential anti-CD20 antibodies. So you need to have a proper weekly positioning in the initial 3 successive weeks. Only then you get the disease under control. So you have an initial induction sort of a thing, and then you consolidate with monthly, and then you have a maintenance. So this is how obinutuzumab works. And to have an effective efficacy, we must have a proper scheduling, and we must take care that we don't delay. So if it is delayed, then we must make sure that we don't wait up to the subsequent dose, and we must administer as early as possible. So what about follicular lymphoma? So even here, the same thing happens. The first week I gave, Second week missed. I'm around day 17. I should not wait for the third week. I must administer the subsequent week as early as possible so that the anti-CD20 efficacy is well maintained in these patients. So, what is the prophylaxis and pre-medications for these patients? So, we all know that if we have to give tumor lysis syndrome prophylaxis, and the tumor lysis depends upon the rate of proliferation of the target tumor and the burden of disease. So, if it is a high grade DLBCL, or if the disease burden is so high, in this set of patients, if you give this potential anti-CD20, you're going to see a tumor lysis syndrome. So for these purposes, we must have a proper hydration. Continuous hydration is very important. And uric or uricostatics like febuxostat or allopurinol or even rasburicase matters in these patients. So patients should continue to receive prophylaxis for these irrespective of subsequent infusion. So what it matters is we must have these are potential anti-CD20. So and we expect tumor lysis in this set of patients. Therefore, having a proper tumor lysis syndrome prophylaxis matters. A continuous urine outflow, maintaining a proper creatinine clearance, and a prophylactic use of febuxostat or allopurinol, and use rasburicase when clinically indicated. The disease burden, the proliferation rate, the renal function all matters when you come to tumor lysis syndrome. So, what is the recommended prophylaxis and pre-medication for obinutuzumab for IRRs in whether it is CLL or whether it is follicular lymphoma? So, corticosteroid pre-medication is recommended for follicular lymphoma patients and is mandatory for CLL patients. So, seeing again that CLL patients have a higher susceptibility for infusion-related reactions than those of follicular lymphoma. The pre-medication for subsequent infusions and other pre-medication should be administered as described. So the hypotension as a symptom of infusion-related reaction may occur during Gazyva intravenous infusions. Therefore, we must withhold antihypertensive treatments 12 hours prior to and throughout Gazyva infusion and for at least 1 hour after administration. So very importantly, if you're planning a Gazyva infusion, we must give corticosteroids in CLL patients, and it is recommended in follicular lymphoma patients. And we must skip the antihypertensive dose 12 hours prior, during, and 1 hour after infusion. And then, what are the pre-medications we use? So CLL day 1 and day 2, you can see intravenous corticosteroid, and then oral analgesic and antipyretics and antihistaminic drugs. So all these three are indicated in CLL patients. So at least 30 minutes before Gazyva infusion, we must use antihistaminic, analgesics, and antipyretics. And we must use intravenous corticosteroids 1 hour before Gazyva infusion. So we should not be in a hurry where we give we give paracetamol, and then we give hydrocot and immediately push Gazyva. And in those situations, you would have a higher infusion-related side effects when compared to giving it 1 hour before, where you quieten the. So when to give corticosteroids, the B cells surface, they are all stabilized, and the mast cells are stabilized, and you don't expect an allergic response. And when you give antihistaminics and antipyretics, you minimize the infusion-related reactions to the maximum. So all subsequent infusions for CLL and follicular lymphoma. So if patients who had no IRR during the previous infusion, then only oral analgesic or antipyretic is sufficient. And again, it has to be given 30 minutes before Gazyva infusion. So if the patients had grade 1 or 2 with the previous infusion, then we add antihistaminic along with oral analgesic, again 30 minutes before infusion. If the patient had grade 3 IRR in the previous infusion, or the patient with lymphocyte counts more than 25 into 10 power 9 per liter prior to next treatment, then we must include intravenous corticosteroids, oral analgesics, and antihistaminics. Remember, steroid is 1 hour before infusion. So very importantly, if it is CLL, corticosteroid is a must 1 hour before, and we must give analgesics, antipyretics 30 minutes before. And if there are no IRRs in the first cycle, then we can completely avoid antihistaminics and corticosteroids. We can only give analgesics or antipyretics 30 minutes before. If it is grade 1 or grade 2 before, then we must include antihistaminic and an antipyretic 30 minutes before. And if there was a grade 3 IRR or you have a higher lymphocyte count of about 25,000, in those patients, we must be giving intravenous corticosteroid 1 hour before and 30 minutes before antipyretics and antihistaminics. So what are the symptoms of infusion-related reactions? So most frequently reported, more than 5% symptoms were associated with an IRR were nausea, vomiting, diarrhea, headache, dizziness, fatigue, chills, pyrexia, hypotension, flushing, hypertension, tachycardia, and these respiratory problems. So very important, what you can note among these is hypotension. So hypotension is very important, and that's the reason why you have to skip 12 hours before and 1 hour after. And during infusion, we must skip the antihypertensive. And we must have corticosteroids, antipyretics, and antihistaminics ready. And we must always infuse these molecules in a setup where we have facilities for resuscitation, like intubation and so on. So infusion rate modification guidelines are that if there was a grade 4 or life-threatening reaction, we have to stop infusion and permanently discontinue therapy. If it is grade 3, then we have to temporarily interrupt infusion and treat symptoms. Upon resolution of symptoms, we have to restart infusion at no more than half the previous rate. If patient does, supposing the patient developed reaction at 200 milligram per hour, then we must reduce it to 100 milligram per hour, and that is the starting rate. If patient does not experience any further IRR, again we can increase or escalate the dose, the rate of infusion again by 25 milligram per hour and so on. So for CLL patients receiving the cycle 1, day 1, dose split are 2 days. The day 1 infusion rate may be increased back up to 25 milligram per hour after 1 hour, but not increased further. So very important. For the first infusion, we must be very careful. Cycle 1, day 1. If the patient experiences second grade 3 IRR, we have to permanently stop and discontinue therapy permanently. So grade 4, straight away permanent discontinuation. Grade 3, if you have start with 50% of the dose in which you got grade 3 and slowly go up 25 milligram per hour and so on. And if you have a second grade 3 IRR, then you have to permanently discontinue obinutuzumab. And then what about grade 1 and grade 2? We have to reduce infusion rate and treat the symptoms. Upon resolution of symptoms, again we can continue infusion. If the patient does not experience any IRR symptoms, infusion rate escalation may resume at the increments as we discussed. For CLL patients receiving the cycle 1, day 1 dose split over 2 days, the day 1 infusion rate may be increased back to 25 milligram per hour, and it should not be increased further. So very important is we must be very careful in CLL patients, especially on day 1 where we are giving 100 milligrams of therapy. So CLL, highest risk, day 1 highest risk. And higher lymphocyte count, again there is a higher risk. So Gazyva should be administered as an intravenous infusion through a dedicated line in an environment where full resuscitation facilities are immediately available. So we cannot infuse in a small daycare where we don't have immediate resuscitation facilities. So these are the guidelines. So if you infuse Gazyva at home or in a place where there is no resuscitation, then these are the guidelines, and we must be careful about these guidelines. So Gazyva infusion should not be administered as an intravenous push or bolus, because these are monoclonal antibodies. They incite extreme allergic responses. Therefore, they have to be given slowly, gradually, 25 milligram per hour, as I discussed, on day 1 for CLL, and then divide into day 2 and slowly increase the infusion rate up to 400 milligram per hour, depending on the tolerance. So isotonic 0.9% sodium chloride solution should be used as infusion vehicle. In majority of patients, irrespective of indication, infusion-related responses were mild to moderate and could be managed by slowing or temporarily halting the infusion. So even we have seen in clinical practice where a lot of patients do complain of itching, bronchospasm, respiratory difficulty, and so on. All these promptly respond to temporarily stopping it or slowing the rate of infusion, giving corticosteroids, antihistaminics, antipyretics, and again resuming the infusion slowly once these symptoms have resolved. Substitution of Gazyva with any other biologic medicinal product requires the consent, of course. If a hypersensitivity reaction is suspected during or after the infusion, we must be careful regarding subsequent infusions. So, what are the contraindications? So, if a patient had an experience of an acute life-threatening respiratory symptom, or a grade 4 event before, or a second occurrence of grade 3, and in patients who have a known hypersensitivity to the excipients of obinutuzumab. So, as such, we don't have contraindications to Gazyva, but only if there was a grade 4 HSR or you had a second episode of grade 3 immune related infusion reaction. In these situations, there is an absolute contraindication for Gazyva. So, what are the special instructions we must use before handling and disposal? So, it should be prepared in an aseptic technique. For CLL cycles 2 to cycle 6 and all follicular lymphoma cycles, we must have a 40 ml of Gazyva has to be withdrawn. The liquid concentrate from the vial and dilute in non-pyrogenic 0.9% aqueous sodium chloride solution. Very important is 40 ml of Gazyva has to be withdrawn. So for preparation of infusion bags for CLL only in cycle 1, day 1 dose, where we administer over 2 days, we must ensure a differentiation of the 2 infusion bags for the initial 1000 milligram dose. The recommendation is to utilize bags of different sizes to distinguish between the 100 milligram dose for cycle 1 day 1 and the 900 milligram dose for cycle 1 day 1 or day 2. So very important is the uniqueness of the cycle 1 day 1 and cycle 1 day 2 in CLL treatment. The first day and the second day has to be divided as far as obinutuzumab is concerned, 100 on day 1 and 900 on day 2, and we must differentiate the bags. So to prepare the 2 infusion bags, we have to withdraw 40 ml of Gazyva liquid concentrate from vial and dilute 4 ml into a 100 ml infusion bag, and the remaining 36 ml in 250 ml solution bag, which contains a sterile non-pyrogenic 0.9% sodium chloride. So we must clearly label whenever we use. So these all look very basic, but when the product is in front of me, when I have to use, all these guidelines are very important. I have to differentiate. If I'm giving CLL, if it's day 1 of therapy, then I must differentiate. I have to give 100 milligram on day 1. I have to differentiate the bag. I must know how much I have to draw and reconstitute, and the remaining I have to keep for the day 2. So what are the special instructions for using, handling, and disposal? So we should not use diluents like 5% dextrose. The bag should be gently mixed. It should not be turbulent. So we should have gentle mixing, and we should avoid foaming because these are delicate monoclonal antibodies. Vigorous shaking may cause loss of potency of these drugs. So parenteral drug product should be inspected visually for any particulate matter. The prepared infusion should be used immediately. If not used immediately, we must store this up to 2 to 8 degrees centigrade in the refrigerator, and it can be stored up to 24 hours. So in special populations, we have limited data, especially in pregnancy and in nursing mothers. We don't have sufficient data, but it is not recommended in pregnant women unless the risk of lymphoma overweighs that of the child. Then we have to give obinutuzumab. Similarly, in nursing mothers, we do not recommend nursing or breastfeeding during Gazyva infusion. So we know that even rituximab and even obinutuzumab, we have to store between 2 to 8 degrees centigrade in refrigerator, and we should ask our patient attendants not to keep in the freezer, and we should keep in the refrigerator around 2 to 8 degrees centigrade. So we should keep the container in the outer carton in order to protect from light, and we should not freeze or and we should not shake this product. So with this in background, I mean, this is a very extensive discussion on how to use monoclonal antibodies. So we know that targeted therapy is a separate dimension of anti-cancer therapy. All these are monoclonal antibodies. We have chimeric, we have humanized, we have a completely human like the Mu maps which we have. So the chimeric has the most, and then we have the Zumab, and then we have the Mu map. So handling infusion related adverse events is a very important thing, because there have been reported deaths if you don't uh, handle these IRRs, especially the first drop, first day matters a lot, especially in CLL. As we saw, the lymphocyte count and the previous history of hypersensitivity all matter before I venture on to what is the dose, what is the dilution I use in these patients. So, it is an unmet need to handle rituximab resistant patients, especially we have data for follicular lymphoma, where in those patients who have progressed on rituximab, the moment they're rituximab resistant, it is very difficult to treat these patients. So in these settings, obinutuzumab comes handy. And if we are using it, and we must remember the initial induction sort of weekly for 3 consecutive weeks, followed by monthly for 6 cycles, followed by maintenance every 2 monthly for 2 years. So with this, I would thank Rosh for providing me the opportunity, and I would thank everyone for your patient listening. I would be happy to discuss if there is any. Yeah, back to you.